Thank you very much. Thank you very much for this very nice introduction. It's really a pleasure to participate in this symposium in honor of Dr. Yusuf. And today my talk will be about how can we use some of the latest development and technology and genomics to help better treat patients. And I will just start with a little quiz. And I know that there's many clinicians here, but I would like just to, think for yourself and, what is wrong with this picture? And, you can come up with a hypothesis, but I will give you a hint. And the hint is this here. And actually, so what was wrong was, that was a Photoshop picture, actually. And, and what happened is that, two individuals were joined. And so these are two real people. And they've combined the pictures. And actually, this leads us to genetics are awesome. You can say this is only my opinion, but no, that's the title of a photography exhibition, actually by an artist from Quebec City that has gained international traction. And basically what this artist has done is to combine together pictures of family members. So in the picture I've shown you, these are actually two brothers, age 30 and 29. Then another example is a father-son picture, 56 and 29. And finally, these are obviously two non-identical twins, age 20. And the point, I want to make here is that when it comes to genetics, intuitively, we all know that genetics are important because, they help determine such traits as facial features. But going back to what's of interest to us now, what I will do with this talk is, first of all, we'll discuss about, what cardiovascular genetics. Can we use it to predict coronary artery disease? Can we use it to predict response to treatment? Can we use it to learn about disease and what to do with unusual cases? So why cardiovascular genetics? Or in other words, why isn't it all about nurture in the environment or upbringing? Well, as I've said before, family traits run in family. So, Michael, you thought you could escape Toronto, but there it is. So, but getting to more serious matters, what about disease? And so, it's obvious that when it comes from Mendelian disease, genetics are tremendously important. This is, cystic fibrosis, the first gene that was cloned for human disease. And there's no doubt, if you have the mutation, both alleles are mutated, you have the disease. If you don't, then you're fine. But, what about this? And this here is a atherosclerosis carotid plaque. And is this heritable? Now, before we delve into that question, I will just have to introduce a statistical concept about how to estimate heritability when it comes to dichotomous traits. So you have the disease or you don't have the disease. And geneticists use, a trick which is called the Liability Model, and it's basically assuming that everyone has an underlying liability that is quantitative, and individuals with a score that's higher than a certain threshold get the disease, and the others, don't have the disease. Now, just to give you an idea, if we were to use this same metric to look at conventional risk factors, how much of the variance in traits such as coronary artery disease would be explained by them? So the example I will take this, and this is just like a benchmark, so we understand the numbers. And let's look at smoking. So, smoking has a frequency of 48% according to Inter-Heart data with the odds ratio of 2.27, corresponding to a population attributable risk of 36.4%. And on this scale, this would correspond to the phenotypic variability explained of 4%. Okay. Now, keeping this in mind, let's look at what is the predicted heritability of coronary artery disease. Now, there are many ways to do this, and one of them is to look at twin studies, so comparing monozygotic versus dizygotic twins. And in one such large study, it was published many years ago in 1994, the heritability was calculated at 0.72, so 72%. Using a family study, a concordant estimate was made at 63%. And using newer methods that can look at unrelated individuals, the component of variants are actually type on the genotyping chip we have was estimated at 41%. So that's necessarily a lower bound because this later estimate depends upon the coverage that we have on our chip. But the point is that, at least, the estimates are consistent between at least 0.4 and 0.7. An interesting component of this, and is, especially when we look at twin studies, is that the risk appears to be, higher when the individuals are affected by the disease earlier in their life. And basically, so that's showing the odds ratio for the set of twins. And so monozygotic versus dizygotic twins, the first thing you'll notice is that the odds ratio for the second twin to have an event is much higher in the case of monozygotic versus dizygotic twins, and so that's consistent with heritability. But the other component here is that the younger is the first twin affected, then much stronger is the risk for the second twin. And this is also consistent with rare mutation having much stronger impact on disease. And indeed, when we look at familial hypercholesterolemia, the overall population frequency is estimated at 1/500. It varies according to population. But in a few studies that have looked at very early MI, the frequency was reported to be up to 12%. So a huge enrichment there. So, but now let's go back to basics. I've started, the talk by, showing, people, facial features. And obviously, we're very good to recognize faces. Actually, we have, whole areas of our brain that are wired to recognize people based, on facial features. That's quite important. And actually, we're so good at this that, we can take pictures of about anything and, see faces in it. And I'm sure that Dr. Huff will have recognized this as a picture of Tom Selleck, right? So how does the heritability of disease or coronary artery disease will compare to the heritability of facial features that we can so easily recognize as part of families? So there are ways to do this, and essentially that's using the same techniques that the Google and Facebook of this world use to tag people in pictures, and it's basically this is all computerized. It's looking at features. So what's the distance between both eyes, the distance between an eye and the tip of the nose and the mouth and everything. And based on this, we can determine the heritability of these features. And quite amazingly, the estimates for all of these features range from 0.46 to 0.79. So in other words, if we look at faces and all facial features track in family, the heritability is very, very similar to the predicted heritability of coronary artery disease. And as with coronary artery disease, unfortunately, we understand very little of that heritability. And overall, only 5 genes have been identified. They only explain 1.3% of the variance in these features. And this leads us to our first big question. So can we predict coronary artery disease? And so the first thing we'll do is, okay, let's, dream a little bit and see if we understood everything about genetics, how good of a job would we be able to do? So basically, if we explain 100% of the heritability using genetic features alone, we would have an area under the ROC curve of 0.95. But this is obviously not realistic in the short or medium term because we are so far away from this. Now, we've come a long way, and this is, in large part thanks to genome-wide technology that allows us to type from hundreds of thousands to millions of genetic variants per DNA sample. And with this, we've been able to identify 46 loci encompassing 104 independent genetic variants that account for 10.6% of predicted heritability. So that's the state of the art in 2013. And just to give you an idea, these variants were done by studying 63,000 coronary artery disease cases and 130,000 controls. Now, just to do a little bit of a numerology, among these loci, 12 were associated with lipids, and that confirms the important role of lipids in CAD, 5 with blood pressure, and 3 with inflammation. But quite interestingly, none that have been identified so far were linked with diabetes. Thus, we know it's a very strong risk factor, but I think that's a very intriguing observation. And overall, with all the experience we've gained in genome-wide analysis, we can make prediction about how many variants we should find. And actually, the latest estimates is that there should be about 1,700 common genetic variants associated with CAD that would collectively explain about 48% of CAD total phenotypic variants. So that's, maybe 75% or so of predicted heritability. Now, can we really predict? So here's, what we can currently do. And basically, if we use the known genetic determinants of coronary artery disease, essentially, we will end up with an area under the curve of 0.59, sorry. So in red are the numbers using current technology and current knowledge. And essentially, if we were to use this as a score and take the individuals with, among the 20% with the highest risk score, 30% of the events would fall into these people, corresponding to another ratio of 1.7. I think the other important point here is that actually, if we take family history alone, we would do slightly better. And family history, I think the point here is that is a very good surrogate for genetics because it captures very well. Now, if we look down the table a little bit, this is, what would be predicted to be achieved should we increase the size of, the genetic discovery studies we're making. So basically, if we're looking at the very last line, when we say there's 10N, so that's instead of looking at 60,000 cases, if we were able to look at 600,000 cases and 1 million controls, then then in the individuals with the 20% highest risk, and combining with family history would identify approximately half of the cases, and that corresponds to an odds ratio of about 4. And that's basically, this is really a technical challenge. The technology is there, both statistical and the lab, and well, actually it's more a financial challenge. And there's no doubt that at some point this will happen, and this gives us a glimpse into the future. So basically, way more predictive, probably collectively stronger than many classical risk factors, but still it's not deterministic. It's still probabilistic. Now let's switch gear here and ask the question: can we predict response to treatment? And again, a little bit of history, and I think it's interesting to know that pharmacogenetics actually had its start in Canada and actually in Toronto. So again, Mike. This was done by Dr. Callow and colleagues in the 50s, and he studied the hydrolysis of succinylcholine by butyrylcholinesterase. And here we have a population distribution of enzymatic activity. And you can see here 3 clear clusters. And essentially, they correspond to the 3 genotypes of a common polymorphism in the enzyme. So you see like the individuals homozygous for the atypical allele have much decreased metabolism. And then in purple, you have the heterozygote individuals. And then in blue, the people with common allele. Now, okay, well, this is one example. But again, if we're to do genetics, we have to make sure that there's some heritability. And actually, that's a very difficult problem because each drug is different. But there's some seminal studies that were done. And one of them was looking at the metabolism of plasma dicuramyl and antipyrin half-life. And the 2 panels compare monozygotic to dizygotic twins, so each pair is linked by a line. And what you can see here is that in monozygotic twins, the metabolism is very, very similar for both drugs, And there's much more variation in diaggregated twins. And mind you, these are still sharing half of their genes. And this suggests that at least for these drugs, pharmacokinetics is extremely irritable. And obviously would like to have this kind of data for all the other drugs, but it's not available. Nonetheless, for many drugs, there are now, there's a clear FDA recommendations of genetic testing. And most of these drugs are actually in the field of cancer, where people use very narrow therapeutic index drugs, and these lend themselves very well to pharmacogenetics. But let's look at an example, which we've worked on in the field of cardiovascular disease. So the example here is Dabigatran. So as you know, Dabigatran etexylate is effective and safe in the prevention of stroke and atrial fibrillation patients compared with warfarin. It's actually given as an oral prodrug that is rapidly converted by esterases, and mainly by the carboxylesterase 1 to the active agent Dabigatran. And because of a 30% CV in exposure to the active metabolite between individuals, we hypothesized that some genetic factors might be involved. So to look into this, we looked at biological samples from the RELY trial that was, led by PHRI. And RELY is a trial of AF patients with at least one additional risk factor for stroke. A large study, 18,000 participants with a mean follow-up of 2 years. And it was a 3-arm study, so 2 fixed doses of Dabigatran and 1 open-label warfarin arm. And now just briefly the results, the lower dose of Dabigatran was as effective as warfarin. The higher dose was superior to warfarin, and both doses had lower minor and major bleeds. So for the pharmacogenetic study, we use a 2-step strategy. In the first step, we carried a genome-wide association study to try to find genetic determinants of Dabigatran etexylate metabolism by studying peak and trough concentration in 1,400 patients. And once these genetic determinants were found, we then tested them for association with safety and efficacy events, and that's the step 2 here. Now, for the first step, we did identify 4 polymorphisms associated at genome-wide significance with peak and trough concentration. As you see, the first one falls near the gene ABCB1, which is a non-drug transporter and is known to be involved in intestinal transport of Dabigatran. So obviously that's a very good biological candidate. And the other 3 polymorphisms actually fall within the carboxylesterase gene region. And again, these are extremely good candidates because carboxylesterase is the gene that is responsible for converting the Dabigatran etexylate into the active metabolite. So taking these SNPs into for testing for safety and efficacy events, and I'm showing you the results. And essentially what we found is that the carboxylesterase polymorphism was strongly associated with the risk of any bleed, with a direction of effect that's consistent with its effect on active metabolite exposure, with a statistically significant and consistent association with minor bleed, and a consistent but unfortunately not statistically significant association with minor bleeds. And just to show you upon survival analysis, and essentially in red here you have the carriers of the protective allele on Dabigatran, and I'm showing here the survival from bleeds. And black, you have the non-carriers on Dabigatran, and in blue and green, you have the individuals on warfarin. So as expected, there's no difference between carriers and non-carriers in individuals on warfarin, but you clearly see a separation of the curves on carriers on Dabigatran with a quite significant treatment times carrier status interaction. So, and perhaps, this could be helpful to help determine the optimal dose, but further research would be needed to be able to conclude so. Now, what can we learn about disease? And I'll just go quickly through this, but I think, beyond applying genetics or genotyping to patient, there's a lot we can learn from genetics that can, translate into, new therapies. A great example is PCSK9. So the gene was found through genetic screen as a target and an important mediator of cholesterol levels. And there's a consistent association with polymorphism in PCSK9 and lower cholesterol levels and lower risk of events. And now there's many clinical trials of this. And another way this can be combined is to assess the causality of risk factors and biomarkers. And that's through the principles of Mendelian randomization. So essentially, this says that if you have a genetic variant that is associated with a risk factor, and you believe that this risk factor is causally associated with an outcome, then logically, the genetic variant itself should be associated with the outcome. And this triangulation can be used, to gain insights into that causality. Obviously, it's not the only tool, but I think it's an interesting one. And it's one where where in the case of LPA, it's shown consistent association between genetic variants and concentration and events. And another example is secretory phospholipase A2. And in this case, there's a very significant association between plasma levels and outcomes. Yet, genetic variants that are associated with the levels of this marker are not associated with the risk of disease. And this would, suggest that actually, this phospholipase is not causal in CAD. And indeed, the, clinical trial, and especially verosplidib, had to be stopped prematurely for lack of efficacy, suggesting that some of these results could have been, predicted through genetics. And finally, the last bit of information is, what about unusual cases? So, and by this we mean either rare or extreme forms of, common disease. And the thinking is that in these cases, they might be caused by rare mutation of strong effect and fall more into the model of cystic fibrosis than garden variety, high blood pressure. So in these cases, we're looking for mutations that are highly penetrant and that will segregate in Mendelian or quasi-Mendelian form. Traditionally, this was done through linkage analysis, in which case you need large families with a few affected members per family to try to narrow down on these mutations. But now, with exome sequencing, there's a real opportunity to identify these mutations much more quickly. So briefly, what is exome sequencing? So first, what's sequencing versus genotyping? When we're genotyping, we're only looking at specific nucleotides that we know vary in a population. Whereas when we're sequencing, we're determining what's the actual sequence, what's the actual base at each nucleotide position. And when we look at exome sequencing versus genome sequencing, is that for genome sequencing, we're just doing everything. Whereas for exome sequencing, we're focusing on protein coding sequences. And the reason to do this is mainly financial, because only about 2% of our genome codes for proteins, so we only have to sequence about 2% of the genome, which is results in great saving. So in this case now, and I will just give you a case that we've seen both on a research basis, but also as a physician, and basically that was referred to me by my friend Carlos Murillo that works at PHI as well. And essentially the proband and his family had sudden cardiac death, very dramatic event. They were vacationing with their family in Montreal, and unfortunately, the husband never woke up and tried to resuscitate and were not able to, but during resuscitation there was some ECG done and a Brugada-like pattern was seen, but this wasn't a clear-cut diagnosis. Now, the family is accordingly so very worried and is seeing my colleague, Dr. Murillo, And the ECG is clearly not normal in this family, but does not fit any known pattern. So what to do with this, and is this Brugada or not? And this is where I get involved when we decide to start the genetic investigation by looking at this nuclear family that you see here with exome sequencing. And just to go quickly, through exome sequencing, we identify about 35,000 variants, of which 6,000 were amino acid altering. Then we further filter for rare variant because we don't expect any causal mutation to be common in a population. That's an unusual phenotype. And so 72 rare mutation. Then we use bioinformatics filter to know how many of them are predicted to alter the function of the protein, and that's 37. And finally, they must fit the pattern of inheritance in this family. And only 7 of these mutations actually, fit the bill. And these are these 7 mutations. And I've put in bold 2 most interesting ones. And the first one is in a gene called Titin, and the other one in CCDC141. So Titin is, we've nicknamed it the cardiac giant. It's a really, really big protein, about 35,000 amino acids. And it's a major component of the sarcomere and has a very important role in diastolic left ventricular wall stress and mutations in which have been involved in dilated cardiomyopathy, hypertrophic cardiomyopathy, and RVC. So this mutation that we found is a very, very good candidate. It's a gene that's known to be associated with arrhythmic phenotypes. And the second mutation is in a gene called CCDC141, has been recently identified for being associated with increased heart rate. So these are not our data, that's the data from a large meta-analysis. And you see there's a common variant that's associated with resting heart rate. And you see the gene in the gene track here. And the mutation we found is a mutation that would affect the function of this gene. Now, what's interesting, if you follow carefully, if you look at the neighbor of this gene here, it's actually Titin here. So we ended up with a fascinating story. And because, we've got 7 rare mutation, and we've got 2 rare mutation and candidate gene that are just next one to each other. And actually the function as the latest gene is not known. We know it's associated with resting heart rate and QRS duration, and has never been reported in the context of certain cardiac death. So all in all, in this case, well, first of all, a no Brugada mutation was detected. That's an important negative. But we ended up with 2 mutations and 2 genes involved in heart regulation. That leaves 3 possible scenarios. So the Titin mutation could be causal and the other one a bystander, or they could both be causal, or maybe CCDC141 is causal and Titin is a bystander. And that's quite enticing because this means that previously in families when Titin was identified as the causal gene, actually might be the other gene just next door that carries a mutation, and suggests that these families could be, should be resequenced. So the whole conclusion here is that, for these rare phenotype, I think we've got great tools that can provide insights. So just to summarize, we're cardiovascular genetics because human traits are heritable. Can we predict CAD? Not quite yet, but there's a huge problem with missing heritability. And can we predict response to treatment? There are many examples in other fields of medicine, but in cardiovascular disease, there's still yet a need for more evidence in that matter. But still, we can use genetics to learn about disease. And certainly now we have tools to really have a crack at these very unusual cases with phenotype that might segregate in families and provide counseling to these families. So on this, I will just like to thank you all for the invitation and for listening. Thank you very much.
Dr. Pare, thank you very, very much for an excellent presentation. Dr. Pare's presentation is open for discussion. Any questions for Guillame? Dr. Hegley.
So thanks, Guy. That was fantastic, and thank you for accepting the invitation to come on this day. I've been really amazed at how rapidly exome sequencing has gone from a research tool to something that's, almost ready clinically. And in fact, we used to receive samples for sequencing for lipid genes, say from the United States, from clinics, and we don't get them anymore because the genetics services there, or the genetics departments, are starting to offer exome sequencing as a clinical service. So I'm wondering, do you think, and then the people that are interpreting them are not necessarily expert in genetics, so I'm wondering, do you think, so can you just comment on this trend in general, and then how much genetic expertise do you think a clinician needs in order to, interpret whole exome sequencing results, or do you think it's all going to be solved bioinformatically? It's just going to be a black box that you just send the sample and then the report will come back with 3 or 4 likely causative mutations?
So that's an excellent question. I think and it's a problem that everyone is facing into the future of this. I really think that exome sequencing will pick up in a big way, and centers like such as Baylor already do thousands and thousands of exome sequences, and I think as people realize the value, there's a lot of these cases that people suspect are genetics or familial, and they don't have an answer, and that could provide clues to it. So I think we have to prepare into offering this as a clinical service and tool. In terms of all this will be done, my own opinion about this is that this should evolve into a type of medical specialty of its own, a little bit like early radiology. You said if someone had a bullet in his leg or not, right? That was used on the fields of war. And it's a little bit the same with these mutations. Like we see nonsense mutation. I think as we refine our interpretation, there will be a need for people that have expertise, and such as the same way that most physicians can read a basic radiography, there's always these cases where you need more refined interpretation. And actually the example I've given here is perhaps one of them, because you get into the situation where actually the 2 best candidates are in 2 genes that are next to each other, and that brings question about segregation in family, where you need to have good insight about recombination and how significant this. So how I see this is that, yes, exome sequencing, I think will take hold and will probably at some point supersede candidate gene sequencing. I think that, most common, normal case could be mostly done through automated or semi-automated fashion, but ultimately this will take a medical specialist to be able to really provide insights into these more challenging cases that we'll see.
Michael Poulter.
I was intrigued by your last study, the family study that you showed there, and I was wondering if you were going to try to sort out what was the causative gene, if anybody's gone and asked the question, what would happen if you knocked out the mouse variant of, like the Titin. Obviously, if you knocked it out, you'd probably be a lethal knockout, but I'm wondering about the other one, whether or not anybody's done that or if that mouse exists.
So, well, the answer, I think, again, very good question. This is a work in progress. So our next steps is to actually type these mutations in further family members. And so now we're trying to have more individuals participate. We're also trying to have access to herd biopsies from the autopsy that was done to see if we can do some gene expression studies there. There is almost nothing known about that gene CCDC141. It's been associated with QRS duration a few months ago in a GWAS, and that's the reason we've picked up on this. So at this point, I mean, we would be very happy if someone was able to knock this out or to look in model systems, what would be the phenotype. But one of our hypotheses is that it actually explains cases where people thought that Titin was linked to a phenotype, but actually the real culprit might be this other gene. The reason being that Titin is so large that if you sequence it, you will always find a rare private mutation. And therefore, you will think that your tag, that this mutation is causal and tracks in the family, whereas actually it might be linked to mutation in the other gene. So the next step as well is try to find, families, and that's very difficult, who had a mutation tracking in Titin with a phenotype, and try to see if we could sequence CCDC141 and see a mutation there as well. I think that'd be a very good population proof of our theory there.
Any last questions for Dr. Pare? Well, if not, I want to thank you very much. Oh, sorry, I missed. No, Dr. Susskind.
I was just wondering, Greg, with respect to the patient's management, with the family's management, is there anything specific going to be done now that you've discovered this profile?
So So the question is, what are the implications on family management in this family? I think at this point it's a bit too early because we're only looking at hypothesis. If we confirm that the mutation tracks with abnormal EKG and further family members, one thing we could do is, cascade testing in the family to try to see if people have more severe phenotypes on the EKG that might require implantation of ICD. And I think this would be the most important, direct translational application of this. But again, we still need to do more work. I guess the other application is that this might help other families, where genes haven't been found yet to explain their arrhythmia.
Guillaume, thank you very, very much for a wonderful presentation, Dr. Pare.